Hello, this is Dr. Harry Brown with the United South and Eastern Tribes Epidemiology Center. And today I'm going to be doing a talk on what healthcare workers need to know about monkeypox. Monkeypox is not a new disease, but it's a new disease to many of us. Usually it's confined to Africa, but in May of this year, there were cases reported in Europe and the United States. On July 23rd, the World Health Organization declared it a public health emergency of international concern. And on August 4th, the US also declared a public health emergency for our country. As of August 5th, there are more than 7,000 known cases in the US. We have the most in the world, once again. There are over 26,000 cases worldwide now reported in 88 different countries, most of whom don't usually see monkeypox. So monkeypox is a viral disease. It's a virus that is in the same genus as the virus that causes smallpox, variola, and the virus used to vaccinate for smallpox, vaccinia. It is a double-stranded DNA virus and comes in two distinct strains, one that's found mainly in the Congo. This one is more virulent and has a higher mortality rate. The other strain, and this is the strain that seems to be circulating worldwide now, is the West African strain. This is less virulent and rarely causes death. It's called monkeypox because it was first isolated in Denmark in the 1950s in a colony of laboratory monkeys. So how is it transmitted? Well, it is transmitted from animals to humans, and there are a lot of different animals that can get monkeypox. The reservoir is likely rodents. It has been known to occur in prairie dogs and squirrels, as many other African rodents. It is transmitted person to person, usually by skin-to-skin contact, but it can also be transmitted on fomites, such as contaminated clothing or bed linens or towels. It is found in respiratory secretions, and it's possible to be transmitted by kissing or other contact with saliva, as well as possibly by large respiratory droplets. It's not thought to be airborne other than if there is an aerosolizing procedure, such as a nebulizer procedure. The virus has been found in body fluids, although it's not known if this is a common route of transmission. It can be transmitted through the placenta, and based on only a handful of case reports, congenital monkeypox is often fatal to the fetus. The current outbreak has been mostly in men who have sex with men. However, there have been cases outside of this demographic, and it is very likely that it will spread to the general population in the near future. So let's talk about the clinical features. It has an incubation period that averages can be as little as 4 or up to 21 days. Classically, there's a prodromal phase. Person has fever, headache, back pain, other muscle aches, fatigue, and a generalized lymphadenopathy is common. This distinguishes it from smallpox. Smallpox generally does not have enlarged lymph nodes. Then usually a rash follows within 1 to 4 days after the onset of the fever. However, during this widespread outbreak, there have been cases where the rash occurred without any prodrome. The rash is easily mistaken for things like herpes simplex, syphilis, other sexually transmitted diseases, chickenpox, shingles, or molluscum contagiosum. So it's sometimes a difficult diagnosis based solely on the rash. But the rash is very similar to smallpox, and the disease is like a milder version of smallpox. Smallpox, when it was around, carried a mortality rate of somewhere around 30%. So let's talk a little more about the rash. It typically starts off as small little red spots, 2 to 5 millimeters. Over the next couple of days, these turn into raised papules, then typically become blisters or vesicles. A couple of days later, they turn into pustules. These can become pretty large. They're often umbilicated, which means they have a small central depression, and they are usually quite painful. Over about 1 to 2 weeks, the pustules will crust over and start to fall off. At this point, they become usually very itchy. Classically, it starts on the face and then moves to the extremities and includes the palms and soles, which is a tip-off that you're dealing with monkeypox. It can appear on oral mucous membranes, the conjunctiva, or on the genitals or the anus. And a lot of cases have been showing up presenting this way. A person is contagious until all the lesions have crusted over and have new skin developed on them for a long time. So this is a typical monkeypox rash seen on the palms of the hands. These are umbilicated lesions. You can see that little central depression there in the middle. It's important to distinguish this from secondary syphilis, which can also present on palms and soles. Syphilis is there on the left and monkeypox is on the right. It can look a lot like a lot of different things. If I saw that top right-hand thing there, I would think chickenpox. These are lesions in various stages of development. Here are some more pictures. Look at the one on the upper left there on the face. This is how it commonly starts. And as you can imagine, this would be quite painful. So as you can see, it can appear many different ways. Most people recover just fine on their own. It's very rarely fatal. To date, out of all those cases in the world, there have only been, I think, 5 reported deaths. Children and immunocompromised people are at higher risk of severe disease and complications, which can include secondary infections. This is why it's not a good idea to pick the lesions open. It can cause a bronchopneumonia, sepsis, encephalitis, and if it affects the cornea, it can cause blindness. So how do you make the diagnosis? First of all, you should maintain a high index of suspicion. There is a PCR test that you can use for confirmation. You should try to get samples from at least 2 different lesions and use at least 2 swabs on each lesion. Swabbing that lesion vigorously, it's not necessary to open the lesion. I would also recommend doing a throat swab because there's a high rate of collection of the virus in saliva. It's very important to use full protective gear when you examine and test a patient because it is very contagious. This should include eye protection. And if you're in doubt, consult state or local health department, or if you have a good infectious disease consultant, that's another person that you could consult. So control of this is going to require the usual public health measures. Isolation is extremely important. Person should remain isolated until the lesions fall off and new skin develops. Contact tracing is essential. Caution should be taken with laundry and cleaning surfaces. Don't shake out the laundry, that could spread the virus. And as I said, use full protection, including eye protection. And then vaccination, which we'll talk about a little more, is very important for the close contacts. Therapy is available. Mostly it's supportive care, but antivirals can be considered for children under 8, for people with exfoliating skin conditions, pregnant or breastfeeding individuals, those who are immunocompromised. And if people have lesions in the mouth, eyes, and genitals, it's recommended that they also receive antivirals. The recommended antiviral is tecovirimat, also known as TPOXX. This can only be obtained from the CDC. It's not available in pharmacies, and there's a process for obtaining it. There are a couple of other newer potential alternatives, cidofovir and brincidofovir, but these are not very available. If someone has eye lesions, trifluridine or vidarabine drops can be used, but this is an off-label use. Now, there are 2 vaccines that are effective against monkeypox. All high-risk contacts of a case should be vaccinated, preferably within 4 days, but you can do it up to 14 days. If vaccinated, it usually prevents the disease. Between 4 and 14, it usually makes for a milder case, but doesn't completely prevent it. The preferred vaccine right now is the modified Vaccinia Ankara vaccine. Trade name for this is Jynneos in our country. This is in the strategic national stockpile. It's given as 2 doses 4 weeks apart in a subcutaneous injection. And this can be given to people with immunocompromised conditions. There's an older vaccine, although this is a modern version of the old traditional smallpox vaccine called ACAM 2000. That's given with a bifurcated needle by poking somebody 15 times in the arm. You have to be trained to do this, and you also have to be vaccinated against smallpox to give this vaccine. There are multiple precautions with this particular vaccine. This is a chart just comparing the 2. You might notice that the ACAM 2000 is a live competent vaccinia virus. The Jynneos vaccine uses a replication deficient modified vaccinia, and it has fewer side effects. So these are contraindications. You can see that the ACAM 2000 has many contraindications, whereas Jynneos, the only contraindication at this point is if you have a serious allergy to one of the vaccine components. I just put this in here to show you that ordering vaccine from the CDC, which is only done at this point by state health departments, is a complicated process. For those health, supposedly the vaccine will be available at some point in the future directly from the Indian Health Service, but as of today, that is not the case. So you must get it from your state health department. There's some good resources out there. The CDC website is really excellent. If you do need to obtain antivirals, you can call the CDC for that, and I've put their phone number here. And I've already mentioned for vaccine, you must get that through your state health department. If you subscribe or have access to UpToDate, they also have an excellent comprehensive chapter on monkeypox. If you want more information, more detailed information, that's an excellent resource. And I would be happy to be a resource as well. You can email me or call me, and my contact information